Welcome to a deep dive. Today, we're really dedicated entirely to synthesizing a core critical concept in psychiatric nursing.
That's right.
We're diving into a foundational chapter on schizophrenia spectrum disorders. Our mission, really, is to cut through the dense textbook stuff
Yeah, get to the essentials.
and deliver the core clinical and biological concepts you need. Give you a comprehensive understanding without, the overwhelm.
Right. So to start, this whole spectrum is fundamentally defined by the presence of psychosis,
Psychosis, okay.
which means there's an alteration in cognition or in perception or, and this is really key clinically, an impaired ability to figure out what's real and what isn't.
Got it?
So we'll connect the biological roots of this complex brain disorder to the symptoms and really crucially to the therapeutic and frankly life-saving role of nursing interventions.
Okay, so let's unpack that spectrum then, because schizophrenia itself is like just one point on this broader range, isn't it?
It is.
When we look at the source material, how does it sort of lay out the related disorders? We need to see where schizophrenia fits in the family, so to speak.
Well, okay, we define them largely by duration and whether mood symptoms are present. So if you see delusions, say, lasting longer than a month, but the person's functioning isn't too severely impaired, that's generally delusional disorder.
Okay, less severe functional impact.
Right. And if the psychotic episode is sudden, quite dramatic, but then it resolves completely within a month, maybe even just a few days, that's brief psychotic disorder.
Sudden onset, quick resolution, and what about the ones that seem, closer cousins to schizophrenia?
Yeah. That's where schizophreniform disorder comes in. It looks symptomatically just like schizophrenia, identical criteria, but it hasn't hit that full 6-month duration needed for the official diagnosis.
So time is the key differentiator there.
Exactly. And then there's schizoaffective disorder, which can be, tricky because you have the psychotic symptoms happening at the same time as a major mood episode, either mania or depression. It's kind of a hybrid.
A mix of both worlds. Now, before we even start thinking about any of those labels, the source is really emphatic about a critical first step, one that, as you said, can be a lifesaver.
Absolutely essential. You must rule out substance-induced psychotic disorder first, or any underlying medical condition. It's paramount.
Why is that so critical up front?
Because the psychotic symptoms caused by substances or medical issues can be so severe, they can perfectly mimic a primary psychiatric illness like schizophrenia. You absolutely have to eliminate physical causes right from the get-go.
Makes sense. Okay, let's shift gears then to etiology, the why behind it. The source is very clear here. Schizophrenia needs to be seen as a brain disorder with really strong biological roots.
It does, and this is where it gets incredibly compelling. The risk is estimated to be about 80% genetic.
80%, that's huge.
It's a massive number, and it's hard to ignore, especially when you look at the twin studies. The source points out a 50% concordance rate in identical twins.
Compared to fraternal twins.
Only about 15% in fraternal twins. So that huge jump, that 50% in identical twins, strongly suggests this powerful genetic vulnerability, which then interacts with environmental factors, of course.
Okay, so genetics loads the gun, environment might pull the trigger. Let's trace this down to the brain chemistry. The initial big clue came from the first-generation antipsychotics, right?
Exactly, their success. They primarily work by blocking dopamine 2 receptors, D2 receptors.
And that really established dopamine's key role in psychosis. But, it's never that simple in the brain, is it? What other chemicals are involved here?
No, it's definitely not just dopamine. Serotonin is also strongly implicated, and so is glutamate.
Glutamate, how does that fit in?
Well, the source notes that drugs like PCP, which mess with glutamate systems, can actually induce a profound state that looks remarkably like schizophrenia. So that demonstrates glutamate's role in potentially causing psychosis. Really, all these neurotransmitters seem to act together, synergistically.
Like a network effect.
Precise.
And of course, environmental factors can push someone who's vulnerable, like stimulant drugs.
Right. Amphetamines, cocaine, they boost dopamine activity. And yeah, they can induce temporary psychosis in anyone, but especially risk in the vulnerable.
And the source also mentions marijuana.
Yes, and it's noted quite frequently. Illicit drugs, especially marijuana, can significantly increase the risk, particularly in those who already have that biological vulnerability.
Okay, so beyond chemistry, there are actual structural differences in the brain too. What does the imaging, like CTs or MRIs, actually show us?
Yeah, the imaging confirms it. We see reduced volume in specific brain areas, for example, reduced volume in the right anterior insula.
That's linked to.
That area has been specifically linked to developing negative symptoms, which we'll talk about later. We also see an accelerated decline in cortical thickness and deficits in gray matter, particularly in key frontal and temporal lobe regions.
Frontal and temporal, so the areas involved in higher level thinking.
Exactly. And if we connect that to the bigger picture, the prefrontal cortex, that's our EEO, right?
Uh-huh.
Responsible for executive functions like planning, judgment, impulse control seems to be compromised.
How do we know that?
Well, PE scans often show lowered blood flow and lower glucose metabolism in that prefrontal cortex.
Meaning it's just not as active.
Right. It means those brain regions governing your ability to plan your day, make sound judgments, manage life, they aren't firing optimally. And that helps explain the really profound functional problems we see down the line.
Which leads us straight into the really difficult comorbidities and risks associated with schizophrenia. Substance use is a huge one.
It's massive. Alcohol and marijuana use disorders are present in nearly half of individuals with schizophrenia.
Is it self-medication, do we think?
It often starts that way, perhaps trying to manage symptoms or side effects, but unfortunately, it almost inevitably worsens the long-term prognosis, makes things much harder.
And the suicide risk is terrifyingly high.
It really is. The source puts the mortality rate at 5 to 10% dying by suicide. That's 5 times the general population rate. And attempts are often highest within those first 3 years after diagnosis.
That's a critical window for intervention.
Absolutely. And beyond suicide, physical illness leads to premature death. We're talking 20 years earlier than the general population, often due to cardiovascular disease and metabolic syndrome, which will link to medications later.
And the source calls out one really specific kind of unusual physical issue nurses need to watch for. Polydipsia.
Yes, compulsive water drinking. It affects about 20% of patients with schizophrenia.
And the danger there is?
The danger is hyponatremia, or water intoxication. It's life-threatening.
Because the excess water dilutes the body's sodium levels?
Exactly. And the symptoms of hyponatremia, confusion, delirium, even seizures can unfortunately mimic or worsen the existing psychotic symptoms. So you might list it if you're not thinking physically. Constant physical status monitoring is key.
Okay, a lot to unpack on the biological side. Let's pivot now from the why to the what. How do these brain changes actually manifest the symptoms? The source groups them into 4 main categories, right?
That's right. Positive, negative, cognitive, and affective symptoms. And together, they impact work, relationships, self-care, everything.
Let's start with the positive symptoms. These are the ones people most often associate with psychosis, I think.
They are. They're the presence of abnormal experiences or behaviors, things like hallucinations, delusions. They're often dramatic, observable, and usually what leads to hospitalization. And importantly, they tend to respond best to medication.
Okay. So the foundation of these positive symptoms, the source says, is an alteration in reality testing. What does that mean exactly?
Reality testing is that usually automatic, unconscious process our brain uses to sort out what's real from what's, well, just in our head. Like knowing a shadow is just a shadow. When that process is impaired, which happens in psychosis, then delusions, these false, fixed beliefs and hallucinations feel completely real, completely authentic to the person experiencing them.
And delusions can take many forms. The source mentions persecutory delusions.
Yeah, the belief you're being harmed, plotted against, watched. Very common. Or referential delusions, thinking that neutral events, like, say, a song on the radio or a news report, contain hidden personal messages just for you.
There are others too, like grandiose, somatic, control.
A whole range. And we also see really dramatic changes in speech, which reflect that underlying disorganized thinking.
The source gives some great examples. Associative looseness.
Right, where the connections between thoughts are just really loose, haphazard. The example given is like, my friends talk about French fries, but how can you trust the French? The logical links are missing or bizarre.
And then there are more extreme forms.
Yes. Word salad is the most extreme, where speech is just a completely meaningless jumble of words. Or neologisms, where the person makes up new words that only have meaning to them.
And clang associations, where words are chosen based on sound.
Exactly. Rhyming or punning, like click, clack, clutch, close. Speech driven by sound, not meaning.
Okay, so delusions are altered beliefs. Speech reflects altered thinking. What about altered perception? Hallucinations.
Right. Perceptual errors. Auditory hallucinations, hearing voices or sounds others don't hear, are the most common. Something like 70% of patients experience them.
And the crucial one for nurses to assess.
Command hallucinations. These are voices directing the person to take an action, often something dangerous to themselves or others, like jump out the window or hurt that person. Huge safety risk.
How can nurses pick up on hallucinations if the patient doesn't report them?
You watch for cues. Tracking motions with their eyes like they're following something, seeming to listen or talk to someone when nobody's there, sudden unexplained changes in their mood or behavior, these can all be indications.
Got it. Okay, that covers the positive symptoms, the added experiences. Now let's talk about the negative symptoms. These sound much more subtle, but the source says they're really serious.
They are incredibly serious, often cause more long-term disability than the positive symptoms, and they are notoriously harder to treat effectively with medication. They represent the absence or reduction of normal functions and emotions.
The source uses the mnemonic of the 6 A's. Can you walk us through those? Which ones really hit functioning the hardest?
Sure. There's anhedonia, which is the inability to experience pleasure in things that used to be enjoyable. Then avolition, a real lack of motivation, apathy, inability to initiate and persist in goal-directed activities.
Those two sound incredibly debilitating.
I'd argue they are among the most debilitating functionally, yes. They really prevent engagement in work, school, relationships, even basic self-care sometimes.
What are the others?
There's sociality, a decreased desire for social interaction, withdrawal. Affective blunting, which is a reduced intensity of emotional expression, flat or blunted affect. Apathy, similar to abolition but more general lack of interest. And alogia, which is poverty of speech, reduced quantity of speech.
It feels like these are harder to treat because you're trying to restore something that's missing rather than suppress something that's added, like a hallucination.
That's a good way to think about it. And this ties directly into the third category, cognitive symptoms. Let's focus on the core functional deficits here.
Okay. What are the main cognitive issues?
We see significant impairment in memory, attention, information processing, and especially executive functioning, that prefrontal cortex stuff again. Planning, problem solving, abstract thinking.
The source gives a good example of concrete thinking, doesn't it?
It does. The nurse asks, "What brought you to the hospital?" And the patient with concrete thinking might say, "A cab." They can't grasp the abstract reason, the underlying crisis like a suicide attempt. They stick to the literal.
That difficulty with abstraction connects to a concept that makes nursing care incredibly difficult. Anosognosia, can you explain that?
Yes, anosognosia is profound. It's the inability to realize that one is ill. And crucially, it's caused by the brain illness itself. It's not just denial or being stubborn.
So the illness prevents the person from seeing the illness.
Exactly. And if a patient genuinely cannot recognize they are sick, logically, why would they accept medication or treatment? This leads to huge challenges with treatment adherence and is a major focus for nursing interventions.
And the last category, affective symptoms.
Right. This involves mood instability. Depression is very common, often co-occurring with schizophrenia, and as we noted earlier, that significantly elevates the already high suicide risk. Dysphoria, hopelessness, these are frequent.
Wow, okay. That's a complex picture. Given all that, let's move into the nursing process. How do we even begin to approach assessment and intervention with all this going on?
Well, assessment always starts with those first two steps we mentioned. 1, rule out medical or substance causes. Thorough physical workup.
Non-negotiable.
Non-negotiable. 2, complete a thorough mental status exam, paying really close attention to assessing their insight and judgment, given things like anosognosia.
And assessing for specific symptoms.
Yeah.
Like hallucinations.
Yes. For hallucinations, you need to ask directly but carefully. Remember, don't validate the perception itself. Ask open-ended questions like, are you hearing anything upsetting? Or what do you hear? Not, what are the voices telling you to do? Right away.
Subtle but important difference.
Very. And assess for delusions. Are they firmly held? What's the content? Is the patient potentially a danger to self or others because of them? And of course, always assess suicide risk, especially if you see depression, hopelessness, or anhedonia. Check their activities of daily living, ADLs, and hygiene too, as self-care often gets neglected.
Okay, assessment done. Now,
Yeah.
intervening. Let's talk about dealing with active hallucinations first. The source gives specific therapeutic communication techniques.
Yes, and building trust is the foundation. With hallucinations, you must never refer to them as if they are real to you. State your reality simply. I know the voices are real to you, but I don't hear them.
Acknowledge their experience, but assert your own reality.
Exactly. Then, focus on reality-based activities. Try to engage them in simple, concrete tasks or conversations about neutral topics to distract them or ground them in the here and now.
And the source suggests a specific intervention for auditory hallucinations.
Yeah, it's a really practical one. Encourage the use of competing auditory stimuli. Things like listening to music through headphones, talking with someone, humming, reading aloud, anything that can help sort of drown out or compete with the voices.
Makes sense. And safety with command hallucinations.
Safety absolutely overrides everything else. If command hallucinations involve potential harm, ensure the patient's safety immediately, increase supervision, maybe move them to a quieter area, and crucially, separate them from any potential target of the command if one exists.
Okay, now intervening with delusions, the approach is a bit different, isn't it?
It is, but trust is still paramount. You need to be open, honest, reliable, build that rapport. Critically, the source emphasizes, never debate the content of the delusion.
Why not? It seems intuitive to try and reason with them.
Because it doesn't work. It usually just makes the patient defensive, angrier, and cling even more tightly to the false belief. You can't argue someone out of a delusion rooted in brain dysfunction.
So what do you do?
You acknowledge the underlying feeling or theme of the delusion without validating the specific false content. Then gently provide a reality perspective.
Can you give an example?
Sure. If the patient says, the doctor is trying to poison me with this medication, you don't say, no, he's not. Instead, you might say, that sounds really frightening, the idea someone might harm you. I know Dr. Smith wants to talk with you about your treatment plan like he does with all patients. The medication is meant to help with the distressing thoughts. I can stay with you while you talk to him if you like.
So validate the fear, clarify the reality, offer support.
Exactly. And when dealing with anosognosia, where they don't believe they're ill, the source suggests finding areas of common ground.
How does that work?
You might say something like, we might disagree on why you're having trouble sleeping and concentrating, but can we agree that the trouble sleeping is a problem we could try to work on? Find a shared goal, even if the understanding of the cause differs. Build trust around solving the problems they acknowledge.
That makes sense. Focus on functional issues they do recognize. And what about intervening with disorganized speech, like that associative looseness?
Key thing there is, don't pretend you understand if you don't. That just breaks trust. Instead, place the difficulty on yourself.
How would you phrase that?
Something like, I'm sorry, I'm having a little trouble following your thoughts right now. Could you tell me more about that main idea again? Use clear, concise, concrete sentences yourself, and gently try to guide them back to the topic if possible. Keep it simple.
Okay, that covers assessment and therapeutic communication. Let's wrap up with pharmacotherapy. The source contrasts the two main generations of antipsychotics.
Right, we have the first generation antipsychotics, or FGAs, also called typicals. Think haloperidol, chlorpromazine. They are primarily dopamine D2 antagonists.
And their main benefit.
They are pretty effective for the positive symptoms, the hallucinations and delusions, and they tend to be cheaper. But they come with a higher risk of challenging movement side effects.
Which brings us to the second generation antipsychotics, SGAs, or atypicals, like clozapine, risperidone, olanzapine.
Exactly. These act on both serotonin and D2 receptors. Their big advantage is that they often treat the positive symptoms. A and D can help with the negative symptoms too.
Which is huge, given how debilitating negative symptoms are.
It's a major clinical advantage. That's why they're often chosen as first-line treatments now. However, they carry their own significant risk profile, primarily metabolic issues.
Before we get to SGAs, let's talk about the big danger with FGAs, those extrapyramidal side effects, EPS. Can you break those down?
Sure. First, there's acute dystonia. This is sudden, often painful muscle stiffness or spasms, usually in the head and neck, like the neck twisting, torticollis, or eyes rolling back, oculogeric crisis. It's frightening and needs immediate treatment, usually with anticholinergic meds like Benadryl or benstropine.
Okay, what else?
Akathisia. This one is really distressing for patients. It's an intense inner restlessness and inability to sit still, pacing, fidgeting. It can easily be mistaken for anxiety or agitation, but it's a drug side effect.
Needs careful assessment then.
Absolutely. Then there's pseudo-Parkinsonism symptoms that mimic Parkinson's disease.
Yeah.
Tremor, shuffling gait, drooling, mask-like facial expression.
And the most concerning long-term one.
Tardive dyskinesia, or TD. This usually develops later, sometimes after years of treatment, though it can occur earlier. It involves involuntary rhythmic movements, often the mouth, tongue and face, lip smacking, tongue protrusion, chewing motions. It can affect limbs and trunk, too.
And the really bad news about TD.
It develops in about 25% of patients on long-term FGAs, and unfortunately, it's often persistent, even if you stop the drug. This is why regular monitoring is crucial.
And the tool for that.
The Abnormal Involuntary Movement Scale, or AIMS test. Nurses need to be proficient in administering the AIMS regularly to detect TD early. It's a key nursing responsibility.
Okay, so FGAs have major EPS risks. Now, SGAs generally have lower EPS risk, but they bring their own major concern, metabolic syndrome.
That's the primary risk with many SGAs, yes. This cluster includes significant weight gain, especially around the abdomen, dyslipidemia, high cholesterol and triglycerides, and insulin resistance, which can lead to type 2 diabetes.
Which dramatically increases the long-term risk of
Cardiovascular disease, heart attacks, strokes. It contributes significantly to that premature mortality we talked about earlier, requires constant monitoring of weight, waist circumference, blood pressure, glucose, and lipids.
And the source notes 1 SGA clozapine has a unique benefit, but also a unique risk.
Right. Clozapine is often uniquely effective, particularly for treatment-resistant schizophrenia, and it's the only one FDA approved to reduce suicidality. Huge benefit.
Yeah.
But it carries the risk of severe neutropenia or granulocytosis, a dangerous drop in white blood cells.
Requiring strict monitoring.
Absolutely. Regular blood draws are mandatory for patients on clozapine.
Finally, the source highlights 3 critical, potentially fatal medical emergencies related to antipsychotics that nurses absolutely must recognize.
Yes, these are essential knowledge. First is neuroleptic malignant syndrome, NMS. It's rare, maybe less than 1% of patients, but it's deadly, with about a 6% fatality rate if not treated promptly.
What are the key signs of NMS?
Severe muscle rigidity like lead pipe rigidity and hyperpyrexia, a very high fever, typically over 103 degrees EC or 39.4 degrees C. Also, autonomic instability, fluctuating blood pressure, tachycardia, and altered mental status. If you suspect NMS, you hold all antipsychotics immediately and initiate emergency medical treatment.
Okay, number 1, NMS. What's second?
Anticholinergic toxicity. This can happen with many psych meds, especially if multiple drugs with anticholinergic properties are combined. Think can't see, can't pee, can't spit, can't, well, you know. Symptoms include urinary retention, blurry vision, dry mouth, constipation, tachycardia, flushed hot dry skin, and crucially, delirium or confusion.
And the nursing pitfall there.
Mistaking the confusion and delirium for a worsening of the patient's underlying psychosis instead of recognizing it as a potentially life-threatening drug toxicity. Big difference in management.
Got it. And the third emergency?
Severe neutropenia, which we mentioned with clozapine, but can technically occur, though rarely with others, defined as an absolute neutrophil count, ANC, below 500 MALDI. This leaves the patient extremely vulnerable to infection. Any signs like fever, chills, sore throat need immediate investigation. Requires stopping the offending drug and protective measures.
Okay. Wow. We have covered a tremendous amount of ground here, synthesized a lot.
We really have.
We've established schizophrenia as fundamentally a neurobiological illness, a brain disorder.
What?
We've detailed the 4 symptom clusters, understanding that positive symptoms are often the most dramatic but treatable, while the negative and cognitive symptoms frequently cause the most long-term functional impairment. And we've stressed that nursing care is absolutely pivotal. It hinges on building trust, maintaining that careful balance of acknowledging the patient's experience while focusing on reality, and critically, expertly monitoring for and managing those potentially dangerous, even deadly, medication side effects and medical complications.
That really sums it up well. And considering the focus in modern care on the recovery model, helping people live full, meaningful lives, not just controlling symptoms and knowing the high rates of premature death from physical illness, things like cardiovascular disease, plus the specific risks like polydipsia and hyponatremia we discussed, it raises an important final thought for our listeners.
Okay.
Given all that, what single non-psychiatric vital sign or maybe physical assessment finding do you think is the absolute most crucial yet perhaps most often overlooked element in the ongoing day-to-day care of patients living with schizophrenia spectrum disorders? Something to really think about.
That is a vital, practical question. Something for you all to definitely mull over as you take this essential knowledge forward. Thank you so much for joining us for this deep dive into schizophrenia spectrum disorders.
Hope it was helpful.
We truly hope this synthesis supports your learning journey and helps you serve your patients safely and effectively.